All right, sorry about that. There's a little technical issue. Okay, so following on what I've just been rambling on before, I'm going to now fast forward from the intraoperative cesarean part and focus more on post-cesarean analgesia. And I expect you guys to continue to follow me blindly in everything I say without judging anything or anything else. A quick few disclosures. I do occasionally receive money from some financial institutions and pharmaceutical companies, device companies, and I've listed them out there, and some of the products I may be speaking about later on. So I showed you this slide earlier about patient preference, and like I mentioned, this is going to be focusing on the pain after cesarean delivery, appreciating that there are side effects that you introduce when treating pain. And this is going to be very much a multimodal analgesic approach, looking at various modalities we can do to try and optimize the pain. Well, starting off with Neuraxial versus systemic opioids, and we've shown this in a number of studies. I've just highlighted the ones in OB, but there are studies outside the OB setting and meta-analysis showing convincingly that if you're going to use an opioid, administer it neuraxially, it's going to be far more effective than systemic administration. And in this particular study done at Stanford, you can see that patients receiving spinal morphine provided better analgesia, at least for the first 24 hours. And I've shown you that you get about analgesia from meta-analysis of about 27 hours, mean weighted difference. But if you look at the study ranges, it'll be anything from 16 to 36 hours of some analgesia. Well, what dose do we have to give to get the optimal benefit? And as we've already mentioned with a lot of the drugs, it is this analgesic ceiling, there's narrow therapeutic index, and trying to get the balance right. So Craig Palmer did a lot of work in this particular area. In one study, they went from 0, no morphine, all the way up to 500 micrograms, seeing if we can find a dose effect and an inflection point beyond which you got no benefit, in other words, the analgesic ceiling. They were unable to secure an exact inflection point or a dose. They said somewhere between 50 and 150, but really there was no clear-cut inflection point. And the problem is the variability in patient responses, and subsequent studies have tried to pinpoint that and have struggled, and I'm going to show you some work at our place as well. But the analgesic ceiling does exist, and you can see nicely in this example with epidural administration that Craig Palmer similarly did, and effects beyond 3.75 milligrams in this study weren't apparent in terms of an analgesic effect, and they actually found more side effects going beyond that. So the dose range I would recommend is about 50 to 200 micrograms, closer more like 100 to 200 micrograms intrathecally, and it's about a 20 to 30 to 1 ratio if you convert to epidural administration. So whatever you use intrathecally, convert back, and it's about 2 to 4 milligrams epidurally. So with the idea of us appreciating that we can't quite get a dose right, we used to utilize 200 micrograms for all our patients. And reading a lot of the literature, we felt that we're probably overdosing, and a lot of our patients did itch, and we thought we would try and decrease our dose. So for a good while, we started using 100 micrograms. We felt like we were being called back a little bit more for pain control, and we jumped back up to 200. And then we used this as an opportunity, as an impact study, to look at the effects of this dose change. We looked at 240 patients. So with intrathecal morphine, and this was subtle differences, and unfortunately this slide is not in your handout, but something we recently published. But if you compare 200 micrograms versus the 100, we found subtle differences in improved pain, both in mean pain scores and peak pain scores, less opioid use, just a small difference, about 10 milligrams, and less intravenous opioid utilization. So this looked great. However, and the side effects in retrospective studies are very difficult to elicit. You've got to look at surrogate markers like the use of antiemetics. But we found an increased incidence, in particular in nausea. And you can see there a twofold increase in the side effects. So this is the quandary that you have where you're trying to give better analgesia, but you're introducing side effects. And this has led to, and you will see next year, we will present data letting the patient select what they want and allowing them to make that own decision, and rather than you selecting it for them. And there's no reason why you can't consider using that in your own clinical practice, although I still don't know if that actually makes a difference until we analyze the data. So that's the best we can get from morphine. Remember, morphine is a hydrophilic agent. Unlike the lipophilic agents, it doesn't get absorbed easily from the blood vessels and the fat cells within the neuraxial space. So it has a very high CNS bioavailability and a very long duration of action. It is the least lipophilic agent that we have, and therefore it'll have the longest duration of action. But showing you the limits of that, the idea was to try and extend it through a better means, and this in particular led to the development of Depadur, which is a drug is available but utilized very infrequently. It was a drug that basically encapsulates morphine in a multivesicular liposome and allows slow release of a drug that gives you a more prolonged duration of action. And in the early studies looked incredibly impressive with up to 72 hours of analgesia shown. So this is a slide from one of our studies where we compared 4 milligrams and 10 milligrams of normal morphine. So 10 milligrams of Depadur compared to 4 milligrams of morphine. This has to be given epidurally. And you can see the solid line of the patients receiving the extended release epidural morphine had much better analgesia. There was a divergence beyond a certain point. Very favorable. We thought this would change the way we land up utilizing this drug in this setting. The big problem we have with it is, as I've shown you already, most of us do spinals, and you have to do either a combined spinal or an epidural technique. There is concern with delayed respiratory depression, and as you're already aware, it's a big problem for us to monitor patients after surgery, especially in a chaotic environment like an obstetric setting. And then we also looked at the local anesthetic interaction. So this is in a patient who gets a top-up for a cesarean delivery. They're laboring and then have to go to C-section. And even an hour after that top-up, if you give the extended release epidural morphine, the local anesthetic can affect the release profile. It starts to behave a little bit more like morphine than actually a sustained release, which can be dangerous if you're giving 10 milligram doses. So it's a drug that just can't really find a nice niche market. We utilize it in select patients that we feel it is a very good analgesic, and like I say, it comes with a lot of issues and logistical problems. I've mentioned already the side effects. We really just have to accept that this is a way of life. Intrathecal morphine or epidural morphine is going to give you similar side effects. It's not better if you give it epidurally versus intrathecally. And you're going to make 2/3 of your patients itch. You'll make a third vomit. You're going to introduce urinary retention, and there is always a potential risk of respiratory depression. My 10 cents worth in respiratory depression is this. Yes, there may be a modest increase in risk of severe clinically meaningful respiratory depression is 1 in several thousands, but you don't reduce the risk by using intravenous morphine, and you probably increase it. So it's, by avoiding it, you may actually increase your overall risk because patients have to get treated for their pain at a later stage. But no matter how we spin it, there is an overdependence on opioids, both with us and our patients. So let's move on to other adjuvants. So I know everyone in this room is using non-steroidals to supplement analgesia, and for very good reason. There are many studies showing a benefit. The numbers needed to treat are around 2. So it's a fairly potent analgesic, and its opioid sparing effect has been estimated to be about 30 to 50%, both in OB setting as well as outside. It also can decrease opioid-related side effects, which has been shown fairly convincing in a meta-analysis by Marin. And the amazing thing about a lot of the non-steroidals is that their propensity to cross into breast milk is very small. They are large, highly protein-bound molecules, so it's extremely safe in a breastfeeding environment compared to an opioid that's much more likely to cross into. Opioids can range from anything from 1 to about 6-7% relative infant dose compared to the 0.2 to 0.6 with non-steroidals. So celecoxib is an agent that you can utilize. I'll just mention this from a Cochrane review showing for it to be a good perioperative analgesic, you need the higher doses. So consider the 400 milligrams, not the 200 milligram dosing. And in the only study in the OB setting, it did not show an analgesic benefit. And it wasn't designed to do it. It was looking at another endpoint. However, consider the fact that there's good evidence that non-steroidals work well, and you should stick with that, but consider this agent if your patients cannot tolerate non-steroidals, or you're worried, or your OB is worried about bleeding risk or uterine atony. The breast milk transfer, Tom Hell's work shows that it's probably in the same range of the non-steroidals, around 0.3%. Acetaminophen has a more subtle analgesic effect. It's estimated to be about 10 to 20 compared to the 30 to 40 with non-steroidals. But it has an additive effect to the non-steroidal, and that's been shown very eloquently in a recent meta-analysis. So it's not used instead of, it should be combined with, and it has a very nice interaction with opioids, and a lot of people describe as synergistic. It does cross into breast milk more, about 1 to 2%, and there are now more recent dosing suggestions to reduce your dose because of liver concerns, in particular in preterm babies, so you definitely don't want to exceed the 4, preferably the 3-gram limit per day. Showing you a nice combination of oxycodone and paracetamol combination working better than intravenous morphine in a post-cesarean section setting. We used to use this combination. We have now separated it, so we give around-the-clock acetaminophen or paracetamol, and we use oxycodone separately with the idea that we have steady-state concentrations of acetaminophen and utilize the oxycodone for breakthrough pain rather than linking the two drugs together. And we've just analyzed data that shows that it's a more effective way of doing that as opposed to using the combination together, as shown here. All right, so that's basically what most people in the room probably do for their cesarean deliveries, and you think you're doing a good job. But the Royal College guidelines, as well as JCO, of pain scores less than 3, utilizing the regime that I've just mentioned, the acetaminophen, diclofenac, and intrathecal diamorphine, which behaves very much like morphine, as about a 38% of patients actually fit within this standard of pain less than 3. So we can do a lot better. And I'm going to use the next half of the lecture to talk about other techniques that we can use moving this forward into the next way of managing patients. So local wound infiltration was ubiquitous for surgery, especially when we did it under general anesthesia. The problem was as we shifted over to a spinal technique, the benefit of it was lost, and most of us don't do the wound infiltration of bupivacaine prior or after cesarean delivery, and the efficacy is minimal, unfortunately. But we do have new devices, as you're aware. There's many studies in the cesarean section setting showing very good analgesia, both with pain scores, in particular pain scores on movement, as well as decreasing opioid requirements. To get better benefit, it seems like a high infusion rate is necessary. The problem with high infusion rates, like 5 mLs per hour, is you get a lot of leakage from the wounds, and patients hate it, and OBs hate it. But there is a potential solution to this, which was shown very eloquently in a French study based on data that we had from inguinal hernia repairs, saying that if you bury that catheter, your continuous wound catheter, under the fascial plane, you are able to get better analgesia, and you can see that graph of above or below the fascial placement. Just a few little mentions about the study is that they did not close the parietal peritoneum, so there could have been a lot of local anesthetic going into the abdominal cavity, and it has been shown that intraperitoneal local anesthetic improves analgesia. So it could have been that effect, but most people feel the reason why it's more effective is the nerves that perforate through the fascial planes and go to the anterior abdominal wall are better numbed in this technique rather than just putting it within the wound. So it's a reasonable approach if you utilize this technique, but I still don't want you to move too far away from the wound. I think the wound is where the action's at, and this is where pain is not only initiated but maintained. And we've done a lot of work within surgical wounds to try and better understand what is going on in this. And I want to just share one fairly hot off the press, interesting finding, which may change the way we eventually start practicing multimodal analgesia. So the graph on the left is from Patricia van der Holm's work. What she did was they compared 3 groups. One group got intravenous diclofenac as well as wound infiltration with local anesthetic continuously. The other group got just wound infiltration, which is in the top the top bar, and the bottom bar down there, it only got wound diclofenac, the same dose as a systemic diclofenac. So despite not getting local anesthetic at the same time, they found better analgesia by administering the same dose of diclofenac within the wound, which is an interesting concept that we can start doing our analgesia all within the wound. Now, this is still very early work, and I'm not suggesting you go out to do that. But we followed this up with a study with our wound catheter where we put a very small dose in, because the feeling was, well, maybe it was just systemic absorption. So we used, in the group K, 30 milligrams of ketorolac over a 48-hour period. So it's a tiny, tiny homeopathic dose, which we thought, and we found significant analgesic benefits as well as it affecting the inflammatory cascade within that. We also looked at an opioid which wasn't quite as effective but had some subtle analgesic effect. So watch this space for details as we improve drug delivery within wounds, the ability to start doing multimodal analgesia right at the site of injury. So Manny did mention this. I'm just going to barely touch on it because of Manny's excellent lecture where he covered everything, but I thought it's important that I don't allow Manny to have the last say in the matter. So I'll give you my 10 cents worth. On paper, this looks like an incredible block. It's exactly what the block we want. We want to get analgesia T10 to L1. That's exactly where the incision is. And all the nerves that are going to the area of surgical site being blocked would be an ideal block, and that's why we had so much hope for TAP blocks. So there's a lot of studies, many alluded to some, but there's now a lot of meta-analyses looking at that, well, 2 in particular. And the summary from this, as Manny alluded to, was that if you do not have the ability to use intrathecal morphine at your practice for whatever reason, then TAP block has a valuable role, and there are several studies you can see from the forest plot in the top one showing that there is benefit to this technique, and it is worth doing it. But if you use intrathecal morphine, 2 studies on this showed no difference. And if you compare it to intrathecal morphine, it is not a replacement for intrathecal morphine. And this has been shown also by 3 studies. So that's the evidence for TAP blocks. It has a very small niche market. And we've been trying to find a good role for it. And yes, routine use, if you're not using intrathecal morphine, we certainly do that. So where can we apply it to? And you look at various selected patients. These are the ones we select where we will do TAP blocks on. But I think its key role in most patients is as a breakthrough treatment modality. And we recently published a case series looking at this, and we would recommend utilization of it in this setting. So these are patients that you go and follow the next day or the day after that aren't doing as well as you would expect, and patients who are now requiring intravenous opioids to manage their pain, and they're not getting adequate benefit from that, or they're using escalating doses. These are the patients we target with our TAP blocks, get them comfortable then, and then manage their pain better subsequently. The limitation we have is the fact that it doesn't deal with deep visceral pain, which a lot of the pain is coming from, and it has a limited duration. There is one small case series showing catheter use in the setting to prolong your duration. It's difficult to get the catheter to work continuously, and TAP block catheters may not work as well as, because of the slow continuous infusion, than a bolus technique. It almost seems like you need that spread. So it would probably be more of an intermittent bolus than a continuous technique required. I want to mention gabapentin. Gabapentin is another agent that we thought was going to also change analgesic practice. So if you look at meta-analysis, it's convincing that a perioperative dose makes a big analgesic effect. And this has been shown both with gabapentin and pregabalin. So the natural thing is, let's take it to OB and see what it does. And Jose Carvalho did work on this. His first study looking at 600 milligram dose, very excited stuff. I can show you the graph, the difference between the groups, at least with the acute pain, not in the chronic pain. But it was very exciting, and he followed it up with, well, let's look at a dose range, and looked at 300, 600, and 0 dose, and did not find a good analgesic benefit. So we're a little stuck with how good a drug it is. And if this is the good part of it, there's a lot of bad with gabapentin. If you're going to give it as a pre-incision or a preemptive agent, which is what most setting is indicated perioperatively, you're going to have a lot of transfer to the baby, and this is a neuroactive drug, which I don't personally would want to administer to any one of my patients. If you wait till afterwards, there is a breastfeeding concern, about 2, in some studies showing maybe as high as 5, but the reliable one about 2% transfer, but it is a drug that has potential harm, and you do get quite significant sedation. So this is a drug we once again utilize in individual patients as a rescue block technique, or in patients that are chronic pain patients where their pain is difficult to manage. Ketamine is another adjuvant. If you look outside of OB, small doses. We're not talking induction doses. We're talking 10 or 15 milligram doses. And with this, you get good analgesia, and there's meta-analysis to show that it absolutely has an analgesic effect. the frustrating thing we have, and probably because we do too good a job in OB, is that these subtle doses, yes, after a general anesthetic, have been shown to be benefit, but if you do a multimodal standard analgesic like we've been describing today, it doesn't seem to make a big effect. So once again, it's not a routine agent, it has too many side effects, but it is something you can consider in selected patients, and we're talking a 10 or 15 milligram dose. The problem with all of these drugs, gabapentin, ketamine, they are drugs that have some potential benefit, but we just don't know who of our routine patients will benefit from it. This was a very clever study that utilized techniques we're now playing around with to try and predict pain prior to cesarean delivery or any other operation. This uses temporal summation. It's looking at patients' propensity to have excitable neurons that may potentiate pain. We also look at other modalities of pain inhibition like the NIC. But in this particular study, don't worry about the busy graph, but in patients who had a brisk response, in other words, they were hyperexcitable neurons within this patient, they were more likely to respond from the ketamine. So it really gives birth to the idea of targeted pain therapy. And Kenneth Nelson mentioned a little bit about the future and where we're moving. And if we are able to better identify these patients, you're going to see more individualized treatment plans, ketamine, gabapentin, etc., being agents that you can utilize. The problem is we're not very good at predicting. Studies range from 5 to 50% of pain variations that we can predict pre-surgery. So we still have a long way to go. So that's it. Back in about an hour on CPR, but this is the last on pain. I'll just say there's no wonder drug, and extended-release epidural morphine learned their lesson by thinking it would be a drug that would take over analgesia rather than just slot into our multimodal management. If you're not using morphine, you've really got to ask yourself why and try and change your practices to allow it. You should do around-the-clock non-steroidals and acetaminophen in all patients and treat breakthrough pain with oral opioids of your choice, oxycodone. Codeine's now has a bad name because of one case report which was dubious at best about respiratory arrest and death in a breastfeeding infant, but it's probably an okay agent, but use an oral opioid in about 5 to 10% of patients where pain is not adequately controlled, intravenous opioids, or consider other modalities like a rescue tap block, or utilizing gabapentin or various other agents. Extended-release epidural morphine has a niche market. If you can get it on your formulary, it's a fantastic analgesic, but carries with it a lot of little issues. And that's it. Thank you for your time. Hopefully we'll eventually get to